This conference will now be recorded.
Am I audible? We already discussed in our previous class regarding the anatomy of the large intestine. It starts after the ileocecal valve, opening it into the cecum. Cecum containing as right colon or ascending colon, and then transverse colon, which is the largest part of the large intestine, is the transverse colon. Right colon or ascending colon, and left or descending colon. Both these are retroperitoneal. And descending colon opens into the sigmoid colon, which is a comma-shaped organ attached to sigmoid mesentery. Sigmoid opens into rectum, and rectum finally opens into anal canal and anal verge. So, large intestine is identified by the presence of tinea, 3 tinea, which are known as these 3 tinea are having separate names depending upon their attachment. Tinea aumentalis, tinea libera, which is free, and tinea mesocolica. Tinea mesocolica means the tinea which is attached to the mesentery of large bowel. Tinea libera means free. So, and the other is tinea mesocolica, tinea aumentalis, the one to which the greater omentum is attached. So, next, coming to the interior of the anal canal. Anal canal is roughly 2 to 4 centimeters in length. There are different perceptions of length of the anal canal based upon who is reviewing it. One, the anatomical anal canal ends at the dentate line, whereas when the surgical anal canal ends at the level of the anorectal ring. So both the anatomical and surgical anal canal, they differ by roughly about 1.25 to 1.5 centimeters. So surgical anal canal is ends at the anorectal ring at the apex. So coming to the distal part, the puborectalis and the levator ani, which continues as an external anal sphincter. External anal sphincter is also having three parts which are previously mentioned, but now they are viewed as a single part. Subcutaneous, deep, etc. And the internal anal sphincter. So anal canal opens into the anal verge. So from the anal verge to roughly about 5 centimeters to the perianal skin, it is known as a perianal region. And from beyond the 5 centimeters and to the lateral part, it is known as a squamous cell, normal skin, and it comes into squamous cell carcinoma if any carcinomas arise in this region. So coming in the clinical importance is the carcinomas which arise in the distalmost part of the anal canal. It means which are close to the sphincter. Sphincter salvaging becomes difficult, and mostly they proceed with abdominoperineal resection. So you need to remember one point: the distalmost extension of carcinoma and its position relative to the sphincter is whether the sphincters or the sphincters are involved or not. Depending upon that, we can either salvage the sphincters and perform a low anterior resection or an ultra low anterior resection. If the sphincters are involved and we cannot salvageable, the most commonly used performed surgery is abdominoperineal resection, which leaves the patient with a permanent colostomy. A quick recap of the anatomy, these are the plica transversalis recti or the Houston walls. This is the location at which anal glands are located. These open distally through this anal walls and rectal columns. This is the most common location from which a cryptogranular infection arises and which progresses to perianal abscess or a fistula formation. As the shape is akin to a teeth or it is known as dentate line. As it is akin to a comb, it is known as a pectinate line. So these are the rectal columns which open distal. The rectum and anal canal is composed of outer longitudinal and inner circular muscle core. So the blood supply superior rectal artery, I already discussed it in the previous class. Superior rectal artery, middle rectal arteries which are paid, and the inferior rectal arteries. Superior rectal artery, which is a branch, the final branch of inferior mesenteric artery. The middle rectal arteries and the inferior rectal arteries, they are branches of internal iliac arteries. Inferior rectal artery is a branch of internal pudendal artery, which is in turn is a branch of internal iliac artery. So the supply differs. Inferior mesenteric artery, finally it opens up. The circulation also differs accordingly. So below the level of dentate line, these are known as external hemorrhoids, and above the level of dentate line, there is internal rectal venous praxis, which is known as internal hemorrhoids. So there is a watershed area between both the portal circulation and the systemic circulation can be involved in case of depending upon the location of malignancies. So the drainage is both by portal circulation and by systemic circulation. So this picture clearly represents the vascular supply of large intestine and anal canal. The terminal branch of abdominal the three lateral branches, one celiac artery which supplies the foregut, and the superior mesenteric artery which supplies the midgut, and the inferior mesenteric artery which supplies the hindgut. Inferior mesenteric artery, the branches include a left colic artery which has an ascending branch and descending branch, and at roughly about 4 sigmoid arteries which supply the sigmoid colon. This comma shaped structure is known as sigmoid colon. These branches are roughly about 4 in number. These are sigmoidal arteries which supply the sigmoidal colon, and the final terminal portion of the inferior mesenteric artery is the superior hemorrhoid or superior rectal artery, which is superior rectal artery is single, whereas middle and inferior they are paired. Superior artery, after reaching the top of the rectum, it bifurcates into two and supplies the edges, either parts of rectum. So we already discussed about congenital abnormalities, rectovaginal fistula and rectourethral fistula. These are more common. And the treatment part also we discussed in the previous class. Regarding the diagnostic, you need to remember two X-rays. One is the invertogram and the other is cross-prone lateral position X-ray. So coming to the benign diseases of the rectum and the anal canal, fissure, I think we discussed in our previous class. Fissure is a longitudinal ulcer in the distal most part of the anal canal. The predisposing factors include chronic constipation and passage of a hard, very hard stool. This passage of hard stool can cause minor trauma, which coupled with the sphincter spasm and the high anal sphincter tone prevents significantly lowers the blood circulation, and there will be poor circulation and the wound will heal poorly, and this vicious cycle continues. So the most common location is the midline posteriorly, both in males and female, and lateral, and next is anterior location. These are the most common locations. Locations apart from these most common locations are most commonly due to either inflammatory bowel disease such as Crohn's disease, or it can be due to either some sexual diseases which are transmitted through the anal intercourse. So etiology, there will be high resting anal pressure, which is most commonly due to raised anal sphincter tone. So symptoms include pain, bleeding at the end of this passage of the stool, severe discharge of pleuritis. The patient sometimes holds bowel because of severe pain while passing stool, which further leads to chronic constipation and this vicious cycle continues. This poor blood supply and increased hard stool, and the patient gets constipated, and the cycle continues. So most commonly in acute fears, the management is conservative. We need to reduce the high anal sphincter tone, and one or predisposing factor which we need to correct is the hard stool. So the conservative management includes, one is a laxative for a soft stool, and anal dilatation and local cream application, calcium channel blocker cream, and trinitrate creams, nitrate based ones. So this surgical management includes excision of fissurectomy, or is the most common factor involved is a high sphincter tone. We perform a lateral anal sphincterotomy. I already discussed it in the previous class. We most commonly perform it in the left position as it is easily accessible. At the level dentate line, we divide the fibers of lateral internal sphincter. This reduces the high resting anal pressure. We allow it to heal, and there are newer modalities like Botox injection and other modalities. So this is a most common location we already discussed. Longitudinal ulcer in the distalmost part of the anal canal. Most common location is midline posterior. So treatment includes, one is a conservative method which is most commonly employed in case of acute fissure, like stool bulk forming laxatives, and increase the patient needs to increase his dietary fiber composition. So you tell the patient to eat foods which are high in dietary fiber component, or nowadays there are dietary fiber supplements like Ispabila granules and all. You can use it, a soft stool and laxative, and for improving the local blood circulation and for anal dilatation, there are application of creams like which promote creams. Most of these creams, they promote the healing of the ulcer, like glycerin nitrate creams and calcium channel blocker creams. So the side effects include headache and all. So hemorrhoids, most commonly the dilated arteriovenous plexus, which consists of an internal component and an external component. External component means located below the level of the dentate line, and internal component is above the level of dentate line. We call them as internal hemorrhoids. So hereditary, most common etiological factors include hereditary, means weakness of the anal cushions, and higher pelvic pressures in case of pregnancy, and chronic constipation and straining at stools. The classification of 4 degrees of classification of internal hemorrhoids. First degree, only bleeding. In second degree, the prolapse after defecation, and then spontaneously they are repositioned. Third degree, the prolapsed hemorrhoids need to be replaced manually. They don't go back spontaneously. Fourth degree, they are permanently prolapsed. These permanently prolapsed hemorrhoids, secondary complications like inflammation and thrombosis, etc. So we already discussed in the previous class the most common methods are the injection sclerotherapy, rubber band ligation, and hemorrhoid artery ligation, which is done with Doppler guidance, is a relatively newer modality. And stapled hemorrhoidectomy, it is more specifically called as a stapled hemorrhoidopexy. And age-old surgery is excisional hemorrhoidectomy. So in case of first and second degree hemorrhoids, there is a you can either use sclerotherapy or Barrett's banding. Means there is a syringe. This this is a Barrett's banding apparatus. There is a section with which hemorrhoid is grasped. If you take a closer look at the picture, the hemorrhoid is being grasped, and with a firing of syringe, there will be band application at the distalmost part or the pedicle part, which is the narrowest part. The band gets applied there and stays there. This cuts off the blood supply to the hemorrhoid and gradually it sloughs off. One of the most important complications of this procedure is it can be extremely painful if not applied properly. This is an OP based procedure. If not applied properly, it can be extremely painful and it could also lead to severe severe sepsis like complications. So that is Barrett's band apparatus, and the other is injection of a sclerosant. This first modality, injection sclerotherapy, you inject a sclerosant into the pedicle area, which is polydocanol or tetradecyl sulfate. The sclerosant cuts off the blood. And then the hemorrhoidal artery ligation based upon the doctor. Surgeries, you need to remember 2 surgeries. So the hemorrhoidal, most commonly here also the constipation and all, you need to correct those. So conservative management is sitz bath. Sitz bath means you ask the patient to sit in a tub filled with lukewarm water, filled by either two few drops or roughly about 5 ml of a betadine solution is placed in that lukewarm water, and you ask the patient to sit roughly about 3 to 4 times a day or immediately after the patient passes to it. And then there are local creams and suppositories. These local creams coupled with some vasoconstricting substances which cuts off the blood, which can decrease the amount of bleeding in case of hemorrhoids. Hemorrhoids can cause painless lower GI bleed. And the semi-conservative methods include, we already discussed, injection sclerotherapy and rubber band ligation. The suppositories are just like Delglex suppositories to prevent chronic constipation and passage of normal stool. So one of the important methods include hemorrhoidectomy, which is an open method or a closed method, and staple hemorrhoidopexy. Staple hemorrhoidopexy is a relatively newer modality, which was started by Sir Antonio Longo, an Italian colorectal surgeon. So the operative treatment includes hemorrhoidectomy, which is either open method or a closed method. Open method is also known as a Milligan-Morgan's method, and closed method is a Ferguson's method. So in open method, you allow the lesion to heal by granulation. In closed method, the stitch which is used to ligate the base of the pedicle of the hemorrhoid is continued back and the wound is closed. PPH means the procedure for prolapsed hemorrhoids, staple hemorrhoidectomy. So the complications, as we already discussed, if it is not applied properly, there could be perforation of the rectal and it could lead to rectovaginal fistula and pelvic sepsis and resistance. This image shows the difference between internal and external hemorrhoids. This is a PPH device, which is a circular stapler. By firing of this stapler, you access the mucosal part of hemorrhoidal tissue, which is a relatively painless procedure. You can discharge the patient in the evening. This is the PPH procedure. Just wait, something happened. Am I audible? I don't think anyone is listening to the class. So
the procedure is carried out by using the PPH set of instruments from Ethicon Endosurgery Incorporated.
this is a circular stapler which is used for staple hemorrhoid biopsy.
A circular anal dilator, a purse string suture endoscope, and a suture threader. The patient is positioned in the prone jackknife or lithotomy position. The anal verge is gently massaged and dilated before inserting the dilator. It is recommended that the obturator be inserted alone as part of the dilation process. This will help to prevent damage to the internal sphincter. The obturator is then removed, and the circular anal dilator with the obturator in place is inserted. This pushes back and prevents some prolapse into the anal canal. The skin is milked out to flatten the anagen. This will ensure that the dilator is in far enough to protect the dentate line. The obturator is then removed. The tubing aspect of the dilator, which is 3 centimeters long, will protect the dentate line and the internal sphincter. The flange of the circular anal dilator is provided with 4 slots in order to secure it to the perianal skin so that it is held firmly in place. The circular anal dilator is fully inserted and affixed to the perineum with 2 to 4 sutures. The purse string suture endoscope is inserted through the circular anal dilator, facilitating a circumferential purse string suture of only the mucosa and submucosa. The purse string is positioned near the tip of the anoscope. Use of 2,0-proline SH or monopill on a UR6 needle is recommended for the purse string. The purse string sutures are placed close together, 6 to 10 small bites, to allow better traction of the mucosal prolapse. Each insertion of the needle is near the exit point of the last insertion. The purse string should be at the same level circumferentially. At each stitch, the purse string suture anoscope is extracted, then rotated and inserted again. Rotating the anoscope while it is fully inserted in the circular needle dilator can twist the mucosa and cause an improper asymmetric purse string suture. A finger is placed in the anus, and the purse string is tightened to check for a uniform circumferential closing and no skips or gaps. The location of the purse string suture must ultimately result in a stable line that resides at least 2 centimeters above the Dept line. Once the purse string suture has been completed, the hemorrhoidal circular stapler is fully open and inserted with the anvil placed beyond the purse string suture. It must be confirmed that the anvil crosses the purse string. A careful examination is conducted to confirm that the entire circumference of the mucosa is up against the center of the rod. A surgical knot is made to secure the tissue onto the anvil shaft, and with the help of the suture thread, the ends of the threads are pulled through the lateral channels of the stapler. The stapler is then partially closed, advancing the stapler housing into the anal canal. The stapler housing of the hemorrhoidal circular stapler is longer than the conventional circular staplers and is provided with centimeter marks on its front to facilitate its positioning in the anal canal. The endo is fixed to the rod to avoid accidental detachment, and the stapler shaft is shorter than in the conventional circular staplers. As the stapler is tightened, it is gently pushed into the anal canal, while moderate traction is maintained on the purse string, so that the prolapsed mucosa begins to be drawn into the stapler casing. The stapler is examined to ensure that it is aligned along the axis of the anal canal. Prior to firing, the 4 centimeter mark of the stapler casing is positioned at the level of the anal verge, placing the stapler line at the proper height. If the patient is a woman, check the posterior vaginal wall to be certain that it has not been incorporated in the stapler line. As the stapler is closed completely, the orange duplicator will advance to the low end of the green gap setting scale toward the smaller V, shaped for the shortest closed staple height. Tighter staple compression may reduce the risk of bleeding from the staple line. Be certain not to touch the safety until the device is ready to fire. Release the safety and fire in one fluid motion. Keeping the stapler fully closed for approximately 30 seconds before firing and approximately 20 seconds after firing acts as a tamponade, which may help promote hemostasis. A half to 3/4 turn of the adjusting knob of the stapler facilitates its extraction. Additional turns can cause interposition of mucosa between the anvil head and the upper edge of the circular anal dilator. The purse string suture anoscope is reinserted to facilitate the inspection of the stapler line and application of sutures to any bleeders. Some surgeons may use spongy-like products to improve hemostasis, or a catheter to detect late bleeding. The donut is checked. It should be a 3 centimeter wide strip of rectal mucosa with minimal presence of muscle. The removal of skin tags if present is not recommended because this will result in greater postoperative pain for the patient. The procedure is carried out by using the PPH set of instruments from Ethicon Endosurgery Incorporated. The kit includes a 33 millimeter hemorrhoidal circular stapler, a circular anal dilator,
That's how that is a procedure by which a staple hemorrhoidectomy is done. And, Now the next, I already discussed the open surgical modalities include open method and a closed method. Open method is a Milligan-Morgan's technique, and the closed method is a Ferguson's technique. In both cases, you give a V-shaped circumlinear incision over the mucocutaneous junction, and you gradually dissect the hemorrhoidal tissue from the underlying tissue. You spare the sphincter, and you dissect it towards the pedicle. You transfix the pedicle using a stitch, and then you excise the hemorrhoid. So this procedure is known as excisional hemorrhoidectomy. Whereas in stapled hemorrhoidectomy, it is only the mucosa and the submucosa is removed, and not the complete excisional hemorrhoidectomy. So if after ligating in closed hemorrhoidectomy, the same stitch is used to approximate the wound edges. Whereas in case of open method, the wound is left to heal by granulation tissue. So coming to the perianal abscess, I already told you what is a perianal region. So abscess and fistula, both of them are interlinked. There is an abscess is an acute phase, whereas a fistula is a chronic phase. Most of the abscess they originate in the cryptoglandular region and the rectal columns. Those region, the anal glands are located. They can get infected, which can spread to they travel in different direction. Depending upon it, it is known as 4 types of fistulas are commonly seen. So this is the intersphincteric route of spread. The Parkes classification, intersphincteric is the most common type of fistula, and then there is transsphincteric. The fistula consists of 3 parts. One is the internal opening and the external opening and the intervening tract in between them. So this is the intersphincteric fistula. From the cryptoglandular infection, the fistula tract or the infection travels into the intersphincteric space, and from there it is open into the perianal region. Directly it opens into the perianal region. Whereas in cases of transsphincteric fistula, the name itself suggests the transsphincteric fistula means it traverses the external sphincter. So it is known as transsphincteric fistula and opens into the perianal region. So suprasphincteric fistula, it travels above the level of external sphincter, whereas extrasphincteric fistula, it travels completely above suprasphincter and extrasphincter. These are the 4 types of classification of fistulas. So in acute stage of perianal abscess, there will be pain and severe fever. Anywhere pus under pressure can cause severe pain. The management includes surgical incision and drainage. You incise the most prominent part, Hilton's method to avoid the injury to vital structures. You completely dislodge all the lacules and you drain all the pus, and then the cavity is dusted with betadine soaked gauze, and the wound is left open by secondary healing. Most of these perianal abscess in the chronic stage they cause secondary fistula formation. And depending upon the type of the treatment, fistulas, there are different types of treatment. One is fistulotomy. Otomy means you're opening the tract. Lay opening of the primary tract is known as fistulotomy. Complete excision of the tract is known as fistulectomy. And Saturn means a non-absorbable suture placed and fistula plug replacement. And new techniques like lift method, ligation of intersphincteric fistular tract, and WAFT, video assisted fistular tract closure. So this here you could clearly see the external sphincter, internal sphincter, and the anal glands. From the anal glands, the sphincter wells. These are the different types of sphincter. 4 types of fistulas. Extra sphincter. Fistula. The open fistulectomy procedure, you insert a copper malleable probe into the external opening and you remove through internal opening. You identify both the external and internal openings. If you are unable to identify the internal opening, you inject either hydrogen peroxide or methylene blue into the tract. You dissect the fistulous tract which overlays the copper malleable from its surrounding structures, and then you completely remove the tract. The fistulous tract is sent for biopsy. This is an image of multiple fistulas, which could be seen in case of most commonly you need to suspect inflammatory bowel disease, which the fistula is not healing, and in case of sexually transmitted diseases, in case of homosexual men and all. With this, I conclude my class. Yeah.